Welcome to The Explainer. In oncology, we're in a constant battle to outsmart a relentless disease. Today, we're going to break down a landmark clinical trial, DESTINY-Gastric04, that introduces a really powerful new strategy. And frankly, the results could be a game changer for a very specific group of patients with stomach cancer.
This is the fundamental question we face every day, right? A patient receives first-line treatment, but the cancer adapts, it learns, and it comes back. Finding an effective second line of defense isn't just an academic exercise. It's one of the most critical challenges we face in the clinic.
So here's how we're going to break this down. First, we'll talk about the specific challenge with HER2-positive gastric cancer. Then we'll look at how the DESTINY-Gastric04 trial was set up, dive right into the results, weigh the risks, and then wrap up with the big question. What does this actually mean for our standard of care?
Okay, so let's set the stage. We're zeroing in on a subtype of stomach cancer that has this, unique vulnerability, but it's also incredibly resilient.
The key phrase here, as you know, is HER2 positive. These cancer cells have way too much of a protein called HER2 on their surface, and it basically acts like a beacon. For years, the standard first-line treatment, trastuzumab, has used this beacon to find and attack the cancer. It's our go-to.
But here's the clinical dilemma. What do you do when the cancer just keeps growing despite that initial attack? You need a second plan, a second-line therapy. And while we have options, we haven't had one that's been proven to be clearly superior. This is the exact gap in care that the DESTINY-Gastric04 trial was designed to address.
And this brings us to the trial itself. This wasn't just about seeing if a new drug worked in a vacuum. No, this was a direct head-to-head fight to find out if it worked better than what we're already doing.
So, in one corner, you've got the challenger, a drug called trastuzumab deruxtecan, which we'll just call TDXT. And in the other corner, you have a common standard of care, the combination of ramucirumab and paclitaxel. This was a big, global Phase 3 trial that randomized 494 patients with HER2-positive gastric cancer who had already progressed on that first-line therapy. It's the classic setup to find a new champion.
So what's the big deal with TDXT? Well, it's what's called an antibody-drug conjugate, or ADC. I like to think of it less as a blunt instrument and more like a guided missile, a smart bomb built for precision.
And here's how that smart bomb works. First, the antibody part, that's the trastuzumab, hunts down that HER2 beacon on the cancer cell. Once it locks on, it does something brilliant. It delivers a highly potent chemotherapy payload, a topoisomerase I inhibitor, directly inside the cell. The whole idea is to cause maximum damage to the cancer while minimizing collateral damage to healthy tissue.
All right, now for the part we've all been waiting for. The trial had one primary question: which treatment helps patients live longer? And let me tell you, the results were so decisive that the trial was actually stopped early. So, let's get into the data.
The primary endpoint was overall survival. That's the gold standard for a reason. So did this new smart bomb actually hit its target?
Oh yeah, absolutely. The results were statistically significant and, more importantly, clinically meaningful. Median overall survival with TDXT was 14.7 months. Compare that to 11.4 months for standard of care. That's a difference of more than 3 months, which, as we know, is a huge leap forward in this setting.
Now, let's talk stats for a second. The hazard ratio was 0.70. So what does that really mean for our patients? It means that at any point during this trial, a patient taking TDXT had a 30% lower risk of death compared to a patient on standard therapy. That is a powerful number.
And it wasn't just about survival time. The drug was also much, much better at actually shrinking the cancer. Look at the objective response rate. We're talking over 44% of patients on TDXT had their tumors shrink, compared to just 29% on standard care. This shows the drug is having a really powerful direct effect on the tumors themselves.
Okay, so we've seen the incredible efficacy, but we have to look at the other side of the coin, patient safety. A more effective drug isn't always a perfect drug, and to really understand its place, we have to be just as clear about the side effect profile as we are about the benefits.
When you look at the side effects, you see that both treatments had a high rate of adverse events, over 90%. But here's an interesting point. The rate of severe, or grade 3 or higher events, was actually a little bit lower in the TDXD group. For both, the most common severe issue was neutropenia, which we're all very familiar with managing.
But, and this is a really important but, there is a very specific and well-known risk with TDXD that every clinician needs to be on high alert for. The trial is designed specifically to monitor for it. And here it is. Nearly 14% of patients on TDXD developed drug-related interstitial lung disease or pneumonitis. Now, the critical context here is that the vast majority of these cases, 33 out of 34, were low-grade and manageable. But it is a serious potential side effect, and it requires proactive monitoring and patient education. It's also why patients with a history of significant lung issues were excluded from this trial.
So we have a clear winner on efficacy, but it comes with a specific risk profile that needs careful management. What does this all mean? How do these results actually change what we do in the clinic on Monday morning?
You know, for a scientific paper, the language in the conclusion is pretty bold. The authors state that TDXD may be the preferred second-line treatment option. That's a strong signal that we are likely looking at a shift in the standard of care for this exact patient population.
So if we boil this all down to the clinical bottom line, there are 3 things to remember. 1, TDXD helps patients live significantly longer. 2, it is much better at shrinking tumors. And 3, these major benefits come with a critical trade-off, that known risk of lung inflammation that we absolutely must manage proactively.
And that really leaves us with one last fascinating question to think about. The authors themselves suggest this data is strong enough to warrant studying TDXD in the first-line setting. So, the question for all of us is, did we just find the new best second-line therapy? Or are we actually looking at the future champion for treating this cancer from day one? Future trials will tell us. Thanks for joining me for this explainer.